Mel, good afternoon.
So I don't know if you want to get ready to share your slides. We've got 3 minutes. We're just giving it till 1 o'clock, and then I'll hand over to yourself and Jack.
Wonderful. Okay, I'll put my slides on the screen.
Can everyone hear me okay?
Yes, perfect.
Great, thank you. Just lost the slides, Sinead.
Yeah, sorry, I forgot to share with sound every time.
Don't worry, we've still got a couple of minutes.
Okay,
There's still
ready,
people coming in.
Oh, okay, sorry. Great, no problems.
Give them the two extra minutes, so 1 o'clock, and then we'll start, if that's all right.
Perfect.
So is this the new updated version of the? Oh, it's exciting.
It is, Mel. Yeah, all updated across the county, and we're going to show you as well what it looks like. So, a very short video and kind of yes,
amazing. Okay, I think it's 1 o'clock. We've got about 96 people in so far, but I think we'll have more joining. But I think if we start, that would be wonderful. So I'm going to hand you over to Sinead and Jack, who will formally introduce themselves because I don't know your official titles. And they're going to talk about the new expansion of the Wellbeing Launchpad. So over to you guys.
Thanks, Mel.
Thank you very much. So hi everyone, thank you for your time today. My name's Jack and I work with or for General Practice Alliance. My title is Service Development Manager. I'll just let Sinead introduce yourself.
Yeah, hello everyone. My name is Sinead Galvin. I am a personalised care project coordinator for GPA and have been working on the expansion of the Launchpad.
Great. So yeah, thank you everyone for your time today. We're really excited to show you and announce the new version of the Wellbeing Launchpad, which started off in Northampton town. And through funding from the ICB, we've been able to expand it county-wide. So whether you've heard of it or not before, hopefully you have a bit of an understanding of why we created it and what it's primarily for and kind of the journey that we've had to develop it. Next slide, is it, please? Or is this the journey slide?
This is the journey
It's
slide.
the journey slide. Great, thank you. So back in 2021, GPA realised that there was a gap in how we deliver our social prescribing and also for all clinicians and anyone working with patients. We realised that a lot of people had almost in the back of their notebook a list of services and resources that were for patients, but As soon as someone maybe left the area, all of that learnings about what services are in the local vicinity were sort of gone. So we wanted to create an online tool that hosted all of local services, resources, some groups and different activities that were going on in the local area. So that's primarily why we built it. So yeah, like I say, it started off in Northampton, and we've had really good feedback since creating it, and therefore we approached the ICB, and they kindly funded us to expand it. So we wanted to create a centralised, user-friendly platform that could serve both the professionals and the patients. So it is available to both professionals and patients free of charge. And we definitely encourage you to share this with friends and family as well, so that they can be made aware of all of the great assets of Northamptonshire. So over time, we've also added different things onto the Launchpad, such as long-term health conditions, so that finding groups, resources and support for self-management is just at the click of a button. Next slide, please, Sinead.
So this is over to me. So after success of the Launchpad in Northampton and hearing the feedback about what a useful tool it's been for, mainly the feedback we received was those who are signposting and referring. So we approached the ICB to say, you know, wouldn't this be great if it was across the county? They were really lucky to get some funding from them to do that. So we've been working really hard in the last 9 months to add assets from everywhere. So if you're looking for a walking group in Wellingborough or a crafting group in Corby, you should now be able to find something on the Launchpad. We also listened to feedback. So some of the feedback that we received was that it wasn't as intuitive as it could be. So things that we've also done is make a new look website. So it looks prettier, it should be easy to use. We've amended some of the buttons, so to make it more obvious about how to tell us when there are new assets that you found, or if something's wrong. So it should be more obvious now that you can let us know if something doesn't look right. The most suggested improvement that was told to us by far was, we need a map. We want a map to see what services are out there and where. So we're very pleased to say the map is now live. All you need to do is put a postcode in. In fact, you don't need to do that. You can also just zoom into areas of the county, see what assets are near you. You could see what is down the road for a patient so that they could walk to if they needed to. The other thing that we have done as well is we also are going to encourage professionals to sign up for an account. So there will be professional only resources and information that you can see. And there's also the option for professionals and the public to favourite their most used or searched assets. And this makes it really quick and easy for you to then be able to find it again and share it with a patient. So if you, for example, you're always sharing information about community law or, you know, Macmillan services, if you favourite it, then it's really easy to then share with patients either via WhatsApp, email or text via the Wellbeing Launchpad. So I'm going to show you the little promotional video that we've got. It does also do a little demo of how to navigate the website. It's only 2 minutes long. This video will be available to you in our digital toolkit, but we'll come back to that right at the end. Mel, if you can give me a thumbs up if you can hear, that would be great.
Life throws lots of challenges at us, and taking that first step can be difficult. That's why we created the Wellbeing Launchpad in 2023, bringing all of Northampton's healthcare service, groups and resource into one place. This idea sparked a bigger discussion about having a platform for the whole county. We are excited to have expanded the Launchpad across Northamptonshire. Whether you're looking for support in Corby or a new hobby in Brackley, you can find it in your area. It means finding the right support or sharing a new passion with someone else is now just a tap away. Let's take a look at how easy it is to find what you need. You can search through our wellbeing services, groups and resources by selecting the appropriate age and category from the list. This will bring up a list of results that suits your needs. You can learn more about each listing by clicking on its tile, or by clicking here, you can go to the Resources, Groups or Services external website. Alternatively, you can find the support that you need by typing keywords into the search bar. If you want to explore what groups, services and resources are nearby, you can use the interactive map. Clicking on a pin will bring up the support available, which gives you a direct link to the support page. On each page, you can find helpful information about the support and how you can start using it. You can find a link to the Resources, Groups or Services external website, along with its contact information and location. At the bottom of the page, you can find options for sharing this support with others.
Great.
Okay.
Thanks, Sinead. Okay, so we do realise it's with one of these sorts of tools, it's so important that it's kept up to date, and as we all know, the health care sector is constant, and community care is constantly changing. So updating it is really important. We do have an administrator that works behind the scenes to do that. However, it's also important that we work together and collaborate as an area. So we would be really grateful if you do spot anything on the Launchpad that is inaccurate, or a service has closed down and you see that it's still present on the Launchpad, then please do get in touch with us to let us know. Or alternatively, if there's a service that you're aware of that isn't on the Launchpad but does exist in the area, again, we would be so grateful if you could alert us to that. There are a couple of ways you can do that. So as you can see in the bottom left corner, we've got a dedicated email address, but also through the website, there are different buttons that you can click to either alert us that an asset is inaccurate or closed down, or you can also suggest a new asset to us as well through the website. And yes, and lastly, you can also help us by promoting the tool, of course, as well. So sharing it with your colleagues, and as I said earlier, with friends and family, and patients and clients. That would be really beneficial to them and to us to get the word out there. Next slide, please.
So we do have some ways to help you help us. Is that the right way around? To promote the Launchpad. So we've got both physical and digital materials available for you and your practices. Posters, pens, everyone loves a pen. I've been learning that recently. Calling cards to give to patients. Part of the joy of the Launchpad is that you don't need to know what you're looking for. So there are categories there that you can click on, and then you might find something that is surprising to you and you want to give it a go. So giving calling cards that have, you can see at the bottom left there, have the QR code and the website, so that patients can have a look themselves and maybe try something out. Also a digital toolkit as well. So these are things that could be used on your websites if you wanted to link the Wellbeing Launchpad to your practice website. We've got things for waiting room screens, anything that you can think of would be really helpful if you want to share. If you are willing to help us, if you want any materials at all, if you could put your email address in the chat, I will reach out to you and get in touch to arrange that. And we will also put our email in the chat, because I was going to say, are there any questions, but I don't think we've got time, so I'll put our email in the chat as well. Yes, and I just want to say thank you very much for those who are already using it, that tell me all the time they find it useful. Hopefully it'll be useful to you if you haven't seen it before, especially those outside of Northampton. And thank you to Mel and Craig for having us as well.
Thank you, guys. There is a couple of minutes if there was anything in the chat, but I don't think there is. Will we be able to, do you want us to share anything after here as well? Because we usually share slides and things, well, Craig does. So if there's anything you want me to send out, we can do that as well.
Absolutely, Mel. Yeah, I will get in touch with you. Thank you.
Perfect. Oh, God. Is this in an app?
A question. It's not an app. Yeah, so Sharon, it's not an app, it is a web page, but a web page that is accessible on your phone as well, so you can use it on your phone, and lots of patients do use it that way as well.
Hey. Fabulous. Well, thank you so much. It's exciting. It looks really great, I have to say. So yeah, any promotion you need us to do as well, and we'll put some more bits in the newsletter as well, and downloadable bits if that's helpful, because that goes out this week as well. So yeah, perfect. Thank you very much. Nice to see you both.
Thanks everyone. Bye.
Take care. Bye. Okay, so that moves us on to the next part of the day. Now, the agenda that was originally on our website has changed slightly. So I think I built in a tea break, but talking to our speakers today, so this next part of the day is all around wound care. I think we're going to kind of play it by ear. I think we'll probably do the talks back to back, so you can all get some time back. I think you prefer that than the 10-minute tea break. So with that, I'm going to hand you over to Nicky Sellars, who's the Patient Safety Quality Assurance Improvement Nurse. As we've said, that's a long title, but I love it. And she's going to do the introduction to today's session.
Good afternoon, everybody. Thank you for having me. As Mel rightly said, my name's Nicky Sellars. I work for Northamptonshire ICB in the quality team. My title is massive. We're just in management of change, so it's likely to change, but I think it's still going to be big. So I'm here to set the scene around wound care in Northamptonshire and the wound care framework. So I'll just, can everyone see the slide okay? Is it showing? Fabulous, thank you. Okay, can you see that? Is that big enough for you? Yeah, great. Okay, so why I'm involved from a quality directorate, we were made aware around some concerns regarding management of wounds across Northamptonshire. So we undertook an audit. So I might have met some of you because I did come out to visit some of the surgeries last year, 2020, end of 2024-25, and we looked at what sort of wounds were being looked after by primary care, and we were asked to look at, were those wounds being rightly managed, were those wounds within your contract to manage, and what was the sort of plan to look at that and move it forward. Oh, sorry, sorry, I'm just looking at the chat as we go along. I think that's for the email for the previous slides. Okay, so in Northamptonshire, from a contract point of view, in primary care, the contract is to manage tier 1 and tier 2 on the framework wounds. Is everyone familiar with the framework?
Just having a little look in the chat. We've got a few yeses, so that's a good sign.
Good. Okay, so tier 1 and tier 2 wounds on the framework are healing wounds. So the majority that you look after and manage healing wounds less than 28 days old with evidence of healthy granulation. So those are the wounds right, where someone's either had a knock or they've had a minor injury and they've had sutures to remove, or they've had a knock or a fall or a bang, in the garden, etc. And then those healing wounds that are older than that, but there's still signs of healthy granulation and the healing, they're improving. And we've now got the new wound care pathway in place, which has been launched, directed by the tissue viability team around what dressings and what treatment we're to use. So part of this framework was also about ensuring that everyone had the training and the skills and knowledge in place and competencies to deliver and manage these wounds. So that was what the framework encompassed, what sort of wounds we were dealing with, but also what training was needed to deliver and manage those wounds in both primary care and within NHFT, who were commissioned to deliver those wounds outside that contract that needed more support. Moving on to those sorts of wounds, so that would be hard to heal wounds, wounds that were taking a long time to heal, notwithstanding leg ulcers. If there were signs of healing, they're still managed by yourselves, but it was those ones that weren't healing and were quite static. Deep wounds, surgical wounds, cavity wounds, and then those specialist service wounds where people have got underlying conditions such as diabetes, or they needed a dermatology opinion, or it was a surgical wound. The framework is quite a complex document that I think has been shared across primary care. So we've just adapted the poster to try and make it clear for you. So this has just been updated and will be being shared with yourselves and will be on the website to show you what sort of wounds we're talking about and when to refer on and when to manage them yourselves. So I'll share this document is on the website, but it will also be shared with yourselves, because I think you've all had the previous document, the previous poster, but we're going to share this new one. And this sits alongside those other documents that I've just mentioned in regard to wound pathway documents around wound healing pathway documents, the diabetes pathway, and lower limb wound pathway healing documents. My colleagues in NHFT are going to talk to you a little bit more around training and referrals and process, following on from my introduction. But there will be training available through the hub, and the tissue viability nursing team will deliver some of that training. They're going to be talking later on. There is some e-learning training available there as well, in regard to tier 1 and tier 2 wounds. And then obviously, as I've already mentioned, there's guidelines that sit alongside that, and I know that you've all got those in your practices in regard to pathways to follow for different areas that require wound care. And then this is just a quote from a quality improvement, just to say it's about us all working together really to improve care for the patient and have better systems and processes in place, so we all know who's dealing with what wound, who requires what treatment, and that we've all got the training and competencies available. And that's me. So I was quicker than I thought, as I thought I would be. Has anybody got any questions for me now, or do you want to wait till after we've finished and then come back to me if there's anything outstanding after Sam and the tissue viability nurse has spoken?
I don't think Sam's here yet, actually. So if anybody does have any questions, we can. I've just answered one, which was about the website that you were referring to. So it's the Training Hub website. I may as well just do my little blurb now, actually. So I've shared the link in the chat. So because there was lots of whispers across primary care about this and about wound care, we thought it might be helpful just to have a page on our website, because all of you kind of know our website quite well now. So there's information about the tiered system on there. There's all the documents you'll need that you can download, including that poster that's just been updated, literally like yesterday, so it's fairly new. So some of you that have the old one, you might want to change it out for the new one. The information's the same. It's just we feel that it maybe flows a bit better, and it's got a bit around the escalation and what's involved in that. So we felt that that was an easier one to follow. They're not the nicest posters to follow because there's so much information to put in them. So just bear with us. We've tried to really cram that all in, but hopefully it's a little bit better to understand. I've shared the link, so hopefully you can all access that. I'll just double check if Sam is here. So if we get time, I can always show people around it, but it's fairly self-explanatory. Click on the link that's in the chat, it will take you to the page, and down the right hand side you'll see all the documents that you can download. Yeah, fab. Okay, Sam, I don't know if you can hear us. I can see you've come into the room.
Yeah, I can hear you. Yeah.
Ah, wonderful. Okay, I'm going to hand over to you now, Sam, if that's okay.
Yeah, that's
I'll let
fine.
you formally introduce yourself. And I know you're doing the 2 slides together, is that right?
Yeah, I can do, or I can separate them. It's fine. They're just the last 2 slides, so I can do them later on if you want to.
Whatever works for you. I'll just be letting
fine.
Charlotte know when to come in. So yeah, that's fine.
Thanks very much. Thank you. Thank you. Hi everybody. And thank you for having me this afternoon to present. I'm Sam Stairs and I'm Head of Nursing and AHPs for Adult Community Services. So I cover community nursing, UCR, ICT, but also diabetic high risk foot, SALT, speech and language, and dietetics and things like that as well. So I've just come to give you some information. I had quite a lot of things that I was asked to look at, so I've done a whistle stop tour, but if you've got any questions, then I think we've got time for that later on. So I'll do my best to get through everything. I'm going to share my presentation. It's not very exciting. Just bear with me a moment. Got to find it. Sorry, just having a moment. No, it's not it. Sorry, I'll try again. I think that might be it. Yeah, let me just put it in a slideshow. Can you see that?
Yeah.
Okay, brilliant. Thank you.
Perfect.
Right, I'll try. Let me just get it moving. Sorry. Technical difficulties. There we go. Okay, so I was going to talk to you really about assessment and wound healing and using lower limb wound pathways, the things that we would expect to happen in tier 1 and 2 before the patients come up and are referred into tier 3, basically, and looking at the things that you can do to help and support with that, and also the things that we would like you to refer up and the escalations and triggers that go with those, and the lower limb wound pathway and wound healing, basically, and the points around that. So obviously we've got a rising complexity of wounds that require specialist intervention, and as you've just heard, the Northamptonshire tiered wound model was developed to support that healing with specialist intervention basically as part of it, particularly at tier 4 level, but also at tier 3. So all wounds are going to be triaged and assessed by tissue viability nurses, and it's important that all wounds are assessed and treated comprehensively. So for you in tier 1 and 2, it's important to consider and record all the patient factors before we consider what tier the patient's going to fit into and whether you're going to need to refer them up into the higher tiers of wounds. So we would consider patient factors like comorbidities, diabetes, vascular disease. Their mobility and nutrition is particularly important, particularly if the wounds are pressure related, and those full risk assessments and pressure damage assessments are really important as part of this, and I'm going to talk about that a little bit more later. So we also want to consider the wound factors, so the type of wound, the size, the depth of the wound, any exudate, any odour, any pain, infection indicators, and the length of time that the wound has been present, and also if that's a reoccurring wound. So lots of our leg ulcer patients, for instance, have reoccurring wounds that come back and we have to treat them over and over again. So just being conscious that they may require an escalation if there's reoccurring wounds that seem to heal and then come through again. So that length of time, particularly if it's on the same site and it's opening up again. So the lower limb wound assessment, if we can follow the pathway, just making sure that those patients have had a Doppler and their ABPIs recorded so that you know what compression can be applied, if anything, particularly for those leg ulcers. Considering capillary refill, the temperature gradient, any edema that is present, particularly that if it's out of control edema or it's new, and any foot deforming and deformity and offloading that would be required. Any red flags to consider then with that would be suspected ischemia, which would require referral to vascular services, any spreading infection which is acute, which would require antibiotic treatment immediately and escalation for wound care, any sepsis indicators which would require escalation to an acute setting, any necrosis that has become apparent in the wound bed, and how best we can remove that, thinking about escalation for that. Any new ulcer in a diabetic foot, so remembering that they're high risk patients and they need to be referred to diabetic high risk foot service within 24 hours of that new ulcer being identified, and they can also be referred up into the tiered wound service. Documentation using local wound templates. I believe quite a lot of you have access to Ardens. We use a general wound template that mirrors some of those things that are in Ardens in the community services. I've got some screenshots of the Ardens templates for wound care later so that you can have a look at those if you don't already use them. I think they're quite useful, and there's lots of links inside them for you to be able to use to navigate other parts of the system as well. Making sure that we include photography, and also at this point from red flags consider any atypical wounds, so anything that looks vasculitic, anything that may be malignant, and to consider osteomyelitis, particularly sinuses that don't heal. They can often be very small but can continue to reoccur and exudate in and not heal and have a particular look about them, and they would require MRI scanning to ensure that there isn't any osteomyelitis present. Lower limb wounds, APPI thresholds, so APPI of 0.5, below 0.5 stop any compression and look for an urgent vascular referral. ABPI of 0.5 to 0.8 mixed disease, and that's referral to vascular and tissue viability nurse. ABPI of 0.8 to 1.3 suitable for 40 milligrams of mercury venous compression, and an ABPI of greater than 1.3 is possible calcification, and they require waveform assessment and possibly toe Doppler to go with that. That's all in the lower limb wound pathway, which I think you all have access to, and as part of that we just need to consider things like edema, out of control edema, heart failure, those kind of things that may make compression not indicated. So they would be your red flags. So that's a copy of the lower limb wound pathway. You probably won't be able to read it because the screen's quite small, but we can send out copies of that so that you can have a look. We would want to make sure that those Dopplers and that wound pathway had been followed in Tier 1 and Tier 2 to ensure that when they come to Tier 3, we're providing the correct intervention. So those Dopplers and things should be done before they're referred up to Tier 3. And if you can follow the wound pathway, then that's really helpful for us to be able to make decisions and when we come to triage. But we can give you copies of it so you can see it better. So in the Ardens template, I think you've got something that looks like this, which is very helpful in terms of documenting everything that we've just discussed. So what would be the risk factors? There's lots of boxes that you can click in and out of in order to expand your documentation. So there's pressure ulcers, there's foot screening, there's pulses for your ABPI and Dopplers, there's wound swab links so that you can, if you're swabbing the wounds, you can document that in there. So it's a really useful. There's a dressings formulary, there's compression hosiery formulary in there. There's all the risk assessments must, Waterloo. I think some areas are moving towards purpose T, but we're still using Waterloo in the community at the moment. But I know both acute hospitals use purpose T now, so you may see some purpose T assessments coming through. And there's also medication and pain assessments in there, which is really useful documentation. And if you're using System 1, that's really helpful because we can we'll be able to see some of that documentation, and also we can access some of those things through NCR and summary share care records if you don't know. This is the view for System 1. Unfortunately, I don't have access to EMIS, but this is the view you would see in System 1, but I believe EMIS has a similar template. There's body mapping templates in there for you as well to be able to use. That's also really useful, which gives you all of those things that we've just talked about: the measurements of the wound, the depth, the width, the type of tissue that's in it, any exudate that you can see, any exudate amount, the odours, the pain, all those things are present in that. So it's a good way of body mapping that through, so it's useful to find that. And then this is the pulses and ankle pressure index page for you to be able to document any Doppler assessments that you've done or toe pressures that you've completed. There's also links in there again to the compression hosiery formulary if you needed to look at compression hosiery or ready wraps for anybody. So wound healing then, factors that delay wound healing we all know: poor perfusion, infection, uncontrolled edema, which we've talked about, diabetes, any pressure or shear, inappropriate dressing selection, suboptimal compression. For healing to be optimal, wounds should reduce in size by 20 to 30% within 4 to 6 weeks. And if they don't do that, that's one of the triggers for you to escalate through to Tier 3. They should have healthy granulation and tissue present in the wound, which should look red and healthy. And if they don't, then again, that's something that can be escalated into Tier 3. They should have a reducing exudate, no odour, pain should be improving and should be relative to the wound that's present, and the edges of the wound should be contracting and epithelialisation should be occurring. So those are the things that we would want to look for in a nice healthy healing wound, and these are the wounds that should sit in Tier 1 and 2, and you should be able to see them through to healing, which would be our hope within that sort of 4 to 6 week period. I think you've shared a post, you probably shared a more up-to-date poster than I've got, but this is the Northamptonshire Tier wound pathway. I think the information within it is the same as we've just talked about, but it does give you the clear criteria for the tiers in order to be able to move between them. And one thing I do want to say is that the escalation can go up, but also we would like to be able to step those patients back down for care in Tier 1 and 2 again once things are healing, and that those will be discussed with the clinic nurses and the tissue viability team as is deemed appropriate. So Tier 1 and 2 are simple wounds with healthy granulation, signs of healing. They can be post-op drains and stomas, as long as they're healthy and they look like they're healing well. APPIs of 0.8 to 1.3, which is normal with a normal compression process following that. Wounds that are less than 100 centimetres squared and less than 6 months old. Venous leg ulcer management is okay in tier 1 and 2. No foot deformity, no severe lymphedema, and assess and refer to tier 3 or 4 if your assessment suggests that they require anything outside of what's listed and in the poster, which should be useful for you to be able to navigate between the tiers. So tier 3 and 4 escalation triggers, as we've discussed, no wound improvement in 2 to 6 weeks despite following all the plans in place. So following the wound healing pathway, following the lower limb wounds pathway, making sure that we've applied the correct wound dressings and we've applied the correct levels of compression according to your Doppler results, then that's a trigger for escalation. ABPIs of less than 0.8 or more than 1.3, any suspected arterial disease, diabetic foot ulceration. So some of these will require vascular referral or require diabetic foot referral, as well as referral to the higher tier levels of wound dressing clinics. Any spreading infection, but would require ensuring that we've got antibiotics on board and we've got antimicrobial dressings if appropriate. Any sudden necrosis in the wound and that tissue needs removing so that we can reveal what's underneath. Any pain that's out of proportion with the wound that you can see, or any pain that's increasing, and any recurrent ulceration that we've already talked about. So an upward referral from yourselves, we would require the full assessment documented, which we've gone through the Ardens Template. We've had a look at the ways in which we can record those things simply in System 1 or in EMIS if you're using EMIS. Any ABPI results, and again, we've gone through the template that if appropriate, obviously not all wounds would require that. It would only be your lower limb wounds. Any wound photographs, which would require attaching to the referral that would be sent, complete the referral form to tier 3 or 4. A triage will occur within 5 working days, and then an appointment will be offered or contact will be made within 7 working days. That contact will be made with the patient, not with yourselves, but you'll get the triage summary back from the tissue viability nurse when they've looked at the wound and decided which tier they'll be in. So that will either say that they're going to remain with you and give you some advice and support in a plan, or that they would be coming to tier 3 or 4 and it will tell you which tier that they've been placed into. Our SPOA staff will then make contact with the patient within those 7 working days. Please continue to see the patient until all of that's confirmed and they've got an appointment. We do currently have clinics now running across the county. We've got Kettering, Corby, East Northants. I think we've got a clinic running in Rawns at the moment, with the potential to run one in Thrapston as well. We've got ones running in Northampton Central, and we've got ones running in Daventry. We've only had one patient referred from Brackley, but there is the option to have Brackley clinics if we needed them. I think currently we're seeing that patient at the GP surgery alongside the practice staff, but we can have clinics out there if there are more patients referred in. So patients shouldn't need to travel too far, although they will need to travel probably further than their normal practice levels. So if a patient declines, then you'll receive communication from us to say that the patient has declined. Often that is because the travel is further than they're used to travelling. So some discussion would need to be had between ourselves, yourselves, and the patient then. And then the patient will be seen in the clinic at the agreed location. It has taken us a little while to get all those spoke clinics. We've had some hub clinics running for quite a little while, but it's taken us a while to get the hub clinics up and running. But they are now doing that, and we will look to seek further locations if we've got lots of patients in those areas. In terms of downward referral, so tier 3 clinic staff will provide back with you a clear treatment plan, any re-escalation advice, and confirmation will be sought from you from the receiving practice prior to any appointments being made for you and ceased with us. So you will have all that back in the other direction. And obviously, if you did require re-escalation, then following the same process through again. Just to say a little bit about delegation of care. So registered nurses remain clinically responsible for care. delegated task HCAs require clinical oversight from registered nurses at regular intervals, and wounds should be seen regularly by registered staff. All wounds referred to Tier 3 should have registered nurse oversight, so we just need to make sure that our registered staff are, if you're delegating care to HCAs, then that is totally fine, but making sure that we're continuing to have that clinical oversight for them on a very regular basis, and that if they're coming up to Tier 3 or 4, then that registered nurse oversight is present. As the registered member of staff, you do remain clinically responsible for that patient and for their care, and so being able to see them at a regular interval is important. I've got a little bit of a summary on pressure relief, which is something that we've been discussing across the system. So we've been talking about pressure relief, which has been classically across the system referred either into community nursing or has been referred into community therapy services. That's difficult because I think the capacity issues in both of those sets of services is difficult when patients don't have other nursing or therapy requirements, i.e. they don't have a wound or they don't have a therapy need. So we're looking at expanding that pressure relieving process across the whole of the system. Pressure ulcer prevention training for everybody, and looking at ensuring that everybody has Millbrook low-level training and pins for equipment ordering, so that cushions, mattresses, those kind of things can be ordered. Making sure that risk assessments are completed, and we could see those risk assessments were present in the Ardens template, so you can click in and out of those if you needed to. Waterloo or Pepper's-Tea, whichever it is that we're using, must and asking assessments, making sure that the surface nutrition mobility is considered for each patient, and making sure that we're giving patients information about looking after themselves and looking after their own pressure areas. So the G is about giving information. And I think that's really important part of the health promotion of pressure relief, because sometimes a cushion and a mattress don't really solve the problem. Actually, what we need to give the patients advice about is movement, nutrition, hydration, and those kind of things to ensure that there's movement and they're not sitting continuously in the same place. It's particularly true for people who use mobility scooters and wheelchairs as well. So you might have patients that come into practice who are on wheelchairs and mobility scooters, just checking that they've got some pressure relief on those and that it's adequate and that it's functioning is really useful. So making sure that we check heels, sacrum and bony prominences when we do initial assessments on patients to make sure they haven't got any pressure related damage already. Assessing footwear, which can rub, particularly in our diabetic patients, very important, and check any equipment that they've already got that they're using at home. So they may have seen another service, therapy services or community services previously, and they might already have equipment in the property which may be suitable for their needs. Consideration of provision of pressure relieving equipment if they haven't already got some, or you feel that they require a higher level of pressure relieving equipment given the picture that you're seeing when they come into practice. Supporting community teams of patients under your care. Giving advice to patients on movement, nutrition and hydration, as we've already said. And then there are some links that we're creating with Age Well, who are going to be able to provide basic sort of pressure relieving equipment to patients within their remit. And so there may be the possibility that we can use referral into them for help with some of this if needed. So this is a work in progress. It's not live yet, but we are going to try to work towards having these in process, and there is a framework that's being developed as part of this, so that will be shared when it's finished, really. So primary care, early identification, risk assessment and prevention, and providing equipment and advice is really helpful, and does give that initial part of the pressure relieving information before patients come to community settings and community nursing. Some community nursing interventions for those who aren't able to access health in another setting, so particularly those who aren't able to come up to practices or aren't able to get into outpatient appointments and things like that. and they will also do some education and monitoring. Therapy help for seating, mobility, posture and equipment. So if there's a higher level therapy need, then that, you know, we refer to therapy, and they will do the pressure assessment as part of their assessment, as community nursing will as part of their assessment if they're seeing patients. Same with urgent community response and ICT, who have both nursing and therapy. Patients and carers for self-care, and that's really important, that information giving and making sure that patients are looking after themselves, repositioning themselves, reporting any changes to professionals so that we can react to that in a really quick way is really important, and educating patients to do that is really good health promotion as part of this. So a culture is if you see a patient, own it and don't assume someone else's responsibility, particularly if the patient already has a wound as a result of that. And then early action would prevent harm, and everybody can contribute. I think just as a last part of this, just to say there's training available for everybody if they needed it. I think you can access some of that through your training hub, but also through our tissue viability team at NHFT, and also the acute tissue viability nurse teams are also offering particularly things like VAC dressings and that kind of thing if you needed help with those. Just bearing in mind that, you know, wounds can be healing and have VAC dressings and be sat in tier 1 and 2 as well. So, and I think we've had drains as well, some of the nephrostomy drains and things like that, which can sit in tier 1 and 2. So if you needed any help and education, there are education resources available for you all if you needed them. And I think that's me done.
Perfect. Thank you very much, Sam. I think there was some questions in the chat. I know Charlotte's just joined for the next session, but I just wanted to check that we have got a Q&A at the end in case they want to ask any of you any questions. But I think there was one around heart failure. Isn't it just uncontrolled heart failure that is a contraindication for compression?
Yeah, so I think it's just stable heart failure can be okay. It's just to be aware that that is one of the flags. So just to be aware if the patient does have heart failure, and that, you know, whether it's controlled or uncontrolled, and also the edema that's present, because if you've got a lot of uncontrolled edema, that can be an issue as well. Yeah,
lovely.
That's right.
And I think you did answer this one actually. Somebody put up something about having no clinics in Corby, and you literally, as they put it up, you had said about, is there any way of sharing where all of these are so that staff are aware of where these clinics are? Because obviously people weren't aware that there was any in Corby. So is there anything?
Yeah. So they're at Willowbrook, the ones in Corby currently. But yes, I can share you a list of where they all are.
That would be amazing.
And I can put some bits in the chat as well. So Corby, now there hasn't been, but there are now Corby clinics. They're up and running. They've been up and running for a few weeks now, and the patients are attending. So that is something they can do. And we did have quite a lot of Wellingborough patients that had been referred as well that were attending Kettering, but now we have got Rawns, and there is the possibility to have a Thrapston clinic as well. But again, we haven't had a lot of referrals in that area, so we will stand those spoke clinics up and step them down as the need, a bit like we have in Brackley. But if we did need to see a patient in the surgery with yourselves, then that's totally fine. We've done that with the patient in Brackley, that has worked quite well, because we don't have a lot of patients in that area who have been referred in yet. But as soon as we do have a clutch of patients, then we'll try and find. So the Rawns clinic is actually at the GP surgery in Rawns. And the Thrapston clinic, if we did have one, would be at Green Lane. And we've got Corby Kettering's at St Mary's Hospital. In Northampton, we have got ones running at Cynthia Spencer Hospice, and then we've moved that because it was originally at Campbell House, but we had a problem with the stairs and there was a fire alarm and we couldn't get the patient down, so we've moved it to Cynthia Spencer because that's on one level and it's easier to get the patients in and out. It's a bit more parking there as well. And then we've got Daventry running at Daintree currently, in the outpatients area at Daintree, because I think a couple of people, the text message had sent them into the inpatient setting, but it's in the outpatient area. as I say, we could have some at Brackley Community Hospital as well, but we haven't had a lot of referrals from that area, so we have just been seeing that one patient with the surgery currently. But we can work with you, and if you've got clinic space and you feel that you could some of your patients could be seen in the surgery, we're happy to come to the surgery and work with you on that as well, to help with transport and travel.
Lovely. And then I think Kyle Trinder's put, what is the process if the patient declines?
So we
yeah.
have had that happen. So some patients, and it has mainly been to do with area or transport. So if the patient declines, then some correspondence will come back to you as the referrer to say that the patient's declined. And then what we've done with some of those patients is tried to work together. You know, again, we could look at whether we could see the patient with you at the surgery, if that makes more sense, or we can look at solutions together. But we have been holding them on a waiting list while we set up all of the clinics in all of the areas, but now that process is set up and we've got more clinics in more areas, we will be writing to you to let you know that the patient has declined and wants to some patients do want to continue to be seen at the surgery, and that is difficult, so we would have to have that conversation between us around how that works.
Okay. I think he also went on to say that they did have a patient referred back, but the information that came from the clinic, there wasn't any information. So I don't know if that's something that can be shared with you guys to look at. Possibly.
So there should be a full treatment plan shared back, and I know again it's taken us a while to get everything set up and running as it should be, but there should be a treatment plan and a referral process back to yourselves. So once you accept the patient, then we would stop the appointments in the clinic, and so there will be some communication from the senior nurse that's running the clinic now that should happen. So they will make contact with you, give you all that treatment plan, and then the patient would be transferred back to you. So apologies if that didn't happen, but that is the process that should occur. So if you don't get that information, please let us know.
Now, what I might do, I'll do one more question and then we'll do the Q&A at the end, because I did message Charlotte to get her to come in a little bit early, and I know she's working clinically. So the next question down from that was, I think it was about ordering equipment. How would we access training and a PIN for ordering pressure relieving equipment? So I'll stop at that question once we've answered it, Sam.
So that framework is currently being built, and there will be communications to you about how to access that training as soon as that has been approved, and we can share the framework with you. So it's not currently available, but that's the plan for the future.
And I think, if I remember rightly, there is a GP practice that is piloting it first to see how it works. So we're still waiting to have the feedback from that before it goes across. I think
there's one of the surgeries in Corby that has been the pilot area, but we won't be expecting you to do it until that's launched and the tiered approach to that is launched, and we can get everybody into the training and the pressure ulcer prevention training as well.
Wonderful. Thank you. So I'll pause there. Charlotte, I'm hoping you can hear us. I'm going to hand over to you now. So we've got Charlotte Anderson, who is the tissue viability specialist nurse, who's going to do some slides with us. Hopefully she can hear us. I know she's here.
Good afternoon, everyone.
Hello.
So yeah, I can hear you. Just bear with me whilst I put the presentation into Teams. Okay, it's not going to work that way. I might have to just share my screen. If you bear with me 2 seconds. Technology is not my forte.
No, it's not great when you're a nurse.
So if I share this screen, hopefully everybody can see that. It might just say fungal in pale letters at the moment.
Yeah.
Perfect. I'm just going to pop you on the other screen. So good afternoon, everybody. I've been asked to come and talk to you a little bit about fungal infections in wounds and how to recognise those signs and symptoms and how to effectively treat them. So as Melanie said, my name's Charlotte. I'm one of your tissue viability nurses for the community. We have a team of 6 of us, but I think there's only 4 of us in at the moment. A couple of people are on mat leave, so that's all exciting, but we're all here to answer your questions. So today is about recognising the fungal infections, the differentiation from other conditions, the clinical diagnosis, so what that's going to look like in our patients, and what investigations need to occur, and effective treatment strategies, because it is important to highlight the distinguishing factors, between fungal and bacterial infections, and an emphasis on clinical diagnosis of that and where we move forward in getting those things, or those swabs, say, for example, actioned. So the clinical impact, hopefully that is big enough. I appreciate it's might not be big enough on the laptop or if you're sharing a computer screen, but it's important to highlight the clinical impact of missed fungal infections. So obviously there's an impact of that. So missed fungal infections can cause prolonged discomfort and worsening skin breakdown in our vulnerable patients. Or you might just think, why is this wound not healing? And the fungal infection delays healing by increasing wound maceration and reoccurrent deterioration. It can often be mistaken for bacterial infections, and so antibiotics misuse can unfortunately occur, and it will not help the fungal infection. It can also lead to the disruption of the microbiome and promotes more fungal overgrowth and worsening outcomes, because the bacterial or the antibiotics will treat bacteria, but they get rid of all the good bacteria on your skin that naturally occurs as well. So the importance of early recognition in this. Early fungal infections detection enables us to target treatments and reduce that healthcare burden. So hopefully not seeing your patients as much and getting those wounds healed a bit quicker. So common settings where fungal infections occur, your usual warm, moist skin folds, so under the breasts, the groin, anywhere that has a skin fold, and especially in the summer. As well as between the toes. If we've got a leaky leg or a wet foot wound, so to speak, there's likely going to be a fungal element to that wound just because of where it is on the body. It can also occur in pressure ulcers and around the peri-wound, so especially sacral pressure ulcers and pineal sinuses. It's a very nice, good, moist, warm, healing environment for our wounds, but also we can unfortunately anticipate an overgrowth of fungal in those areas. Patients with incontinence are at higher risk. I believe it's about 22 times more likely to develop a fungal infection due to the prolonged exposure to urine and feces, and it creates, again, exudate or bodily fluids in an area that can then promote fungal infections. Medical devices can also impact where fungal infections occur, so catheters or breathing tubes or any sort of medical device that is on the body, and feeding tubes as well as tracheostomies can also, we need to be considering if the antibiotics hasn't worked, is this a localized fungal infection? So the common organisms encountered in wounds is Candida. So this is the one that is most common around everywhere. It grows especially in our moist wound environments, and it can create that erythema and those satellite pustules, or that satellite spotting in the peri-wound. You've also got Jenny Ball, our IPC and our line manager, tried to tell me how to pronounce this, so if I do butcher it, I do apologise, but dermatophyte, I can't pronounce it, she's going to laugh at me when I tell her, can cause those dry, scaly areas, so it might look like dry skin, but it will usually be satellited around the wound. And the clinical differences in that and how that presents in our patients is the Candida can present with that warm erythema, redness, pustules, and the other one can show as scaly lesions with a central clearing and a bit more of a defined edge. Some more classic signs are that it can usually be bright red or dusky red skin, and the satellite lesions are usually around where the moisture is occurring, or sometimes there might be a residue or white film. Interestingly, pain is often mild compared to when a bacterial infection. So when we are reviewing our patients, it's really important we're assessing that pain. So if there is a considerable amount of pain present, we might be thinking it's bacterial infection. But if there's less pain and it doesn't resolve with the use of antibiotics, it's likely to become a fungal infection. You can also get mixed as well, which we'll go on into a little bit. So moisture from incontinence, so that's sweating or the wound exudate, increases the fungal risk, but also worsening by occlusive dressings, which create that warm, airless environment for the wounds. Metabolic and physical factors, so we want to be thinking intrinsic factors as well for our patients. Patients with diabetes or obesity have impaired skin integrity and an immune response, so can put them at more predisposed for fungal infections and their persistence. Reduced mobility, if we're not moving and grooving enough, then unfortunately it can get those bugs trapped on the skin a little bit more. And as well as hygiene, I mean, our feet are the one thing that touches the floor hundreds and thousands of times a day. So we're always picking up bugs through that area of our feet. So if we want to be thinking about fungal infections on our feet, is the biggest takeaway I'd say from here, because it is the most common site to get them. We also have our immunosuppressed patients, so any patients that sort of go through chemo treatment, or they might have a autoimmune disease which causes their immune system to be dysregulated, and also prolonged antibiotics can have a disruption, as we've highlighted, on the skin flora. So here is just a side-by-side comparison to what fungal versus what bacterial look like. So as we've highlighted, the pain is mild to moderate with a fungal infection. The borders could be well defined, or they could have satellite areas, and this is not common with a bacterial infection. Exudate could be minimal if it's just a fungal infection, but also you'd need to be considering if we've got a big wet leaky leg, is there a fungal infection? Because obviously the increased exudate is causing more fluid in that area. And they do not have an odour, whereas a bacterial infection, I'm sure we've all smelt the delights of a lovely wound infection in your nursing time. And at the bottom there, a fungal infection is not going to improve with antibiotics. So how fungal infection is confirmed. So fungal infection is primarily diagnosed through your clinical signs, so visual assessment, symptom history, treatment response. The role of laboratory tests, so it's really important. So skin scraping can be done, but it's not, you can only do it if you have the sharp debridement skill, so it would have to be considered by dermatology. However, we can swab to the affected area and ensure the swab request. So when you're putting through that swab request on ICE, you're listing all of the signs and symptoms. So what colour is the exudate, how wet is it, how long have those symptoms been there for, and you're wanting it to rule out a fungal infection, and you want to break down any mixed coliforms, I believe microbiology said, on that swab request. So the more information we're putting on our swab forms, that goes for bacterial infections as well, it makes the lab's job easier to diagnose and help get that for your patients. So swabs can be effective for that area. We would be considering skin scrapings if the patient did not respond to an antifungal treatment. So as highlighted, if we've got patients that are immune compromised, or if they're on specific specialist target therapy, then we should be referring to specialists such as dermatology more frequently, just to ensure that we're getting the right fungal treatments and to make sure it's not going to cause any side effects or stop them having their treatments. Believe it or not, it's very hard to find wound images on Google of a fungal infection in a wound. You can find fungal infections for every anatomy part of the body, but you cannot find it related to wounds. So these are a few that I've found that highlight that they are fungal infections around the wound, and hopefully you can see the difference in their appearance there. So we've talked about recognising that fungal infection. We've talked about what it compares to in regards to a bacterial infection. So we want to be treating them. So reducing the moisture, can we increase the padding or the absorbent pad to that area? Can we increase the frequency of visits so that moisture is not sat on that skin for a long time? Topical antifungal treatment is also suggested. So topical antifungal treatments such as your clotrimazole, which is in Canesten, I believe off the top of my head, or you've got them with a bit of a hydrocortisone in as well. So you've got Canesten HC, I think Dactacort do one as well off the top of my head. And that needs to be applied thinly daily for 2 weeks. And then once the treatment has resolved for 2 weeks and the symptoms have disappeared, you must continue it for another week after signs and symptoms have disappeared to truly ensure that the infection has disappeared. So here we go into short-term use of the antifungals with that steroid combination. So if you see a HC at the end of it, it's likely that the antifungal cream has also got a steroid element in that. It can reduce inflammation, but should be avoided. So we wouldn't want to be putting that on long term because it will thin the skin eventually. So systemic antifungal therapy is reserved for severe or recurrent cases, and this requires medical review of timely treatment escalation. So you've gone through your topical antifungals, it could be a sinus wound, and there is evidence to suggest that fungal, although you've treated the external fungal infection, it might be at the bottom of the wound bed where we can't reach. So we would be considering with your GP, or if you're a prescriber, reviewing their bloods and considering an oral antifungal treatment as well. So common pitfalls with fungal infections is repeated antibiotics, mistaken maceration for infection, or the overuse of steroid creams, but also more importantly, stopping that treatment too early. So whilst we're using our antifungal creams, we need to be considering what primary dressing we're putting on. If it's a steroid-based cream, so those ones such as Trimavate as well is a very good one, we want to be putting that on a dressing that does not have another active component, such as silver, inidine, because we don't want to be messing with that the skin flora too much. So we would recommend that you apply that with a Trauma. If you've got a localized antifungal infection, the use of ErgoClean AG should help resolve that infection. But if it is more widespread, especially around the toes area, those bugs have multiplied a bit too much. So you'd want to be considering your topical antifungal treatment creams. So recognising fungal infections. So is the area red, moist, itchy skin? And does it look satellite, or is it with clear borders? Assessing the treatment factors. So if they have not responded to antibiotics, consider the moisture or occlusion as contributing factors to the skin deterioration as well. Environment and therapeutic care. So the treat the environment alongside the antifungal therapy, so ensure the full treatment has been completed, like we said, and past those treatment symptoms or the signs have resolved. We do that for another 7 days to ensure that there is no fungal left on the skin. So ultimately, this can improve patient outcomes, get those wounds healed a bit quicker. So we want to early recognise those fungal infections and make sure that we're doing everything we can whilst we're looking after our patients. I think I spoke a bit too fast because it was supposed to take me 20 minutes, but is there any questions for tissue viability whilst I'm here?
Just have a look in the chat, Charlotte. There is some questions, but I don't know if they're TVM related, so we'll just have a look. Somebody has put, who's a service run by nurse-wise? Will it be TVNs or community nurses? Just the patient know who they'll be meeting. I think that's when they're
the clinics aren't tissue viability led, so they are led by community nurses, but we do work in partnership with them. And if you've been in practice nursing for a while, you might have sent us a referral directly to tissue viability. But if we deem it a tier 4 patient, they're reviewed as per the previous process. So nothing's changed in regards to how we review the patients. I hope that makes sense, Sam. I hope I did it right.
Somebody else put, who mans the wound care clinics? Are they TVN led? Which you've said yes.
They're not TVN led, so they're not led by our service. Sorry, so we will just how the practice nurses already access our service is how we have continued within the clinics.
Okay, perfect.
If you suspected a patient.
Yeah, there's one from Mags on there.
So it depends what bandaging you're using. You need, if it's compression bandaging, you're going to need to continue with your compression bandaging. But think about it as a short-term loss for a long-term gain. Because if we don't treat that fungal infection and you don't commence daily dressings, and it can be a bit of a challenge with capacity. But if we don't treat it right, then you're going to forever, that patient's wound journey is then going to be compromised and they're likely not going to heal and the infection could get worse. So if it's compression bandages, it depends on the level of compression. So if they're in full compression, so your 40 millimoles, you could consider maybe a wrap in the interim just to reduce the bandage wastes whilst you're using your antifungal treatments. But if they are in 2-layer bandage, I don't see a Zetrovit and a yellow line if it's not causing the patient any harm could be used.
Perfect. I think there's a lot around questions around clinics, etc.
So oh no,
yes.
you go first. I was just reading the Sorbasan. I was like, I've not seen Sorbasan pads for donkeys. I don't think you can get them anymore. So I would be looking, have you tried your Zetrovit, and if you've tried your Keramax, I would recommend maybe considering a referral to us, Harriet, because if your Zetrovit's not working on daily dressings to reduce the moisture, there might be another factor or another, I call wounds jigsaw puzzles. If you've had a joint visit with myself, we need all the jigsaw puzzle pieces to get that wound healing. So it might be considering different options or different treatment options that we've not considered previously to maybe help reduce that exudate. Sorry, Sam.
That's okay. I was just going to pick up and answer some of the questions about the clinic. So just to be clear, the clinics are being run separately from community nursing. So while we were setting up in that setup process, there has been some community nursing inputs, but the staff that are being employed for those clinics are being employed separately from community nursing, and there are senior members of staff being employed as well as junior members of staff. There is no HCAs in those clinics. They're all registered nurses. There will be a band 7 nurse as a clinic lead. At the moment, we've got that covered with temporary staffing, but as we go forward, that will be covered by permanent member of staff. So they are separate. All of the referrals go to the tissue viability team for triage. They review all of those wounds and then they let you know which tier the patient has gone into. The tier 4 wounds they have regular contact with. The tier 3 ones come into clinic and they will give advice and support as requested by the clinic staff. So it's being led by the clinic staff that have been employed, and the tissue viability nurses are working with those in a similar way than they work with you. You ask for advice, they give advice. They will come to the clinic if needed. They'll come and meet somebody at home if needed. That the same sort of situation as before. There's a separate referral form. So there's a referral form for the tier 3 and 4 clinic, which we can share with you, and that can be sent over. I think it's an email, isn't it, Charlotte?
Yes. So the clinic form is sent back to SPOA, and the TV. And if you're just wanting specific tissue viability advice, you send it to us. Normally it's going to be it's an amazing service, and I'm really excited to see where it goes, because it's going to give our patients a lot more access. I can see Alice has dropped us in it about toe Dopplers. We're still waiting the funding, Alice, unfortunately, for a toe Doppler machine. But I believe, Sam, they might have got toe Dopplers within the clinic. I'm not sure what Doppler equipment they were able to procure.
Yes, I think we have purchased toe. Well, it includes toe Dopplers in the clinic, and obviously diabetic high risk foot also have toe Dopplers, and some of the community nursing teams do have access, don't they?
But if it's a leg that doesn't have any wounds on it, but can't fit a big cuff around it, always ping us a referral. We can help advise, but unfortunately it wouldn't meet the criteria for a tissue viability visit, because there would be no open wounds to me. It's more of a equipment issue, but you could always consider vascular, as they've got every cuff under the sun available to them as well.
Lots of questions coming in, which is great. Somebody did put earlier, Sam, where does the referral actually go to on system 1, as it's on system 1?
So the referral is an email, and it goes to SPOA. We'll send you the forms, and I think it's got the email address on the form, hasn't it, Charlotte? So if you fill in the form and then you email it to SPOA, and then SPOA will put it into the triaging caseloads for the tissue viability nurses to look at, and then you will get an email once that triage process has taken place to say what tier that patient is. So you'll get some communication back from the tissue viability team to let you know what tier that patient has gone into, and then we will make contact with the patient themselves to book the clinic. The SPOA do that, so they will ring the patient and they will make that appointment in a relevant clinic in that area. If there are problems, there are now a set of letters that are coming back to you to let you know that there's a problem if the patient declines, or if there's an issue with travel or transport. So those things we can discuss with you in more detail. If we needed to work together in order to support a patient, then that's absolutely fine, but there'll be some communication back to you if the patient has declined. We had been holding them on a waiting list, which is because we didn't have the satellite clinics, but now we've got those satellite clinics set up. You will get some communication to say that we've either tried to contact the patient 3 times and we haven't been able to, or the patient has declined, and then we would hope that we could have a discussion all together, I guess, around what we do with that person. If we can attend the GP surgery with you, then we'll try to do those kind of things or find a solution, basically.
Lovely. And I think if you can share everything, slides and the referral forms, we'll make sure when everybody fills in the because after our PLT we send certificates etc. when they do the feedback form, so we can, if everything's sent across to us, we can send it all out to everybody so they've got it. That might be best. So if you just send everything to me, that would be fab.
That's fine.
I think Sandra Cox just mentioned that tier 3 and 4 nurses are now seeing patients in the morning clinic at the Cottons rather than St Mary's Hospital.
Yeah, that's that. So the Cottons is the East Northants clinic at the moment, and we do have the potential to have one in Thrapston as well if we needed to. We've got clinic space there, but we haven't had a lot of referrals from that area. So again, it's kind of working it through. And if patients can attend Rawns at the Cottons, then they can. But yes, that's been set up now.
Lovely. And then we've got a question from Harriet. Are the TVN able to come into practices to teach how to apply VAC dressings, or are we meant to refer to the tier system?
So if it's a skilled and it's a simple VAC dressing, then absolutely. Harriet, if you're able to email our tissue viability email address, I can put you in contact with the clinical nurse trainer from Smith & Nephew Company, and they'll be able to provide a lunch and learn service sort of for you, teaching you how to do so, only because our capacity is I think about 3 working weeks to get into you, so that she'll be able to get into Kathy, her name is, she's lovely. She'll be be able to get into you a lot quicker.
Perfect, thank you. Somebody's put the issue with vascular referrals is that they are so busy, it's taken months to even get an initial appointment with them for patients.
Yeah, I do recognise they are a very busy service, and I think within Northamptonshire, from talking and liaising with other tissue viability nurses up and down the country, we're actually ahead of the curve with our compression and the way we treat our patients. Believe it or not, it may not feel like that all the time, but that's a big thank you to everyone in the room learning today. So I do recognise they are busy. Unfortunately, it's not, I work in collaboration with that department, but it's not a department I work within, but we are following the process to refer to vascular. So that I think we just have to keep referring, I'm afraid. And if you do think that patient is deteriorating, do we need to is it an urgent vascular appointment? Is it a routine vascular? Do we need to escalate up if that patient is deteriorating?
Lovely. If a patient with an ulcer has monophasic pulse, would you still apply full compression if ABPI is okay?
It's not as cut and dry as that, Debbie. It depends. Does that patient have any arterial signs and symptoms? Are they sleeping with their leg down because of pain, or are they able to lie in bed with their legs up? It would be your full holistic assessment to answer that question. If the answer is no, they don't have any peripheral arterial disease symptoms, then yes, absolutely, we'll be putting them in full compression. But it's more about that holistic assessment and listening and talking to your patient about what their actual symptoms are than a straight answer. I hope that clarifies.
Thank you. There's a question about housebound patients. How do we request a Doppler for housebound patients?
That would go through the community nursing team if it was needed. It does depend, I think, on exactly what's required. So we'd have to look at the individual, but you can refer and see, and we can have those discussions if needed.
Okay. I think we've got another one. Are they still holding their lymphedema 6 weekly clinics?
We don't have a lymphedema clinic within Northamptonshire, so I'm assuming, Charlene, you mean the one set up by Vascular? At Vascular, yes, I believe they are. I've not been told otherwise, but if we have got significant lymphedema patients, you can apply for funding to the ICB and they can be seen. I believe it's called Out of Tertiary Care, and Leicestershire and Derby and St George's Hospital within London will accept significant lymphedema patients.
Thank you. I think that's all the questions. I think we got through them all quite quick. We certainly got through the slides really quick.
Sorry. That was a bit
No, it's great. We're giving people the afternoon back, which I'm sure they've got lots of things to do as well as yourselves. Is there any more questions from anyone whilst we have everybody here? See anybody typing? No, I don't think there is. Thank you, ladies, for coming today. I think if anything else comes through, I'll see that it goes to the right person. If you guys can help with any other questions that come through. If you send everything from today that you can share in terms of slides, then I'll make sure that that's added to Craig's list. So when people fill in the form, that goes out to them, so they've got all the information. And I'll also probably add some of the snippets that you've all spoke about today onto our web page that we were just discussing earlier on. And I've put the link in the chat about our web page. It only got put up yesterday, so there's still more to be added to it. But it's just nice to have a centralized point to be able to get all the information. You don't have to look everywhere then. We'll try and have everything on that page. In terms of training, so you've probably noticed on our website, we've got all the leg ulcer and wound care training. Everything is to be booked through the training hub. So any of that The way it used to happen before was through NHFT, and it all got a little bit messy. So if you're a primary care nurse, you need to go on an update or any of that training, you book through our website, and then we collate that list and send it to NHFT. And it's a way that we're able to know where our data is and understand who's due an update, who's not. And I think it kind of helps NHFT as well, who's obviously trying to manage lots of different bookings. Now, I did want to mention the wound care one. We've currently got 15 people waiting to go on that one, and we have been told by NHFT that there isn't any more spaces for this year. So we're waiting to have a meeting when I think Paula Love is back, just to kind of discuss where we go from there, because obviously we've got primary care nurses that still need to access this training. So we will, once we've kind of got to the bottom of that, or if we need to look elsewhere, we'll put it in an email, a targeted email out to all the nurses. I think since I've been chatting, there may have been some stuff going in the chat. I don't know if you ladies have seen. Let me see. Dr. Sylvia Marriott is a private lymphedema specialist in Wellingborough, £50 a session for lymphatic drainage. Is there any specific training to be able to do manual Dopplers in practice, or is it a case of in-house see one, do one? No, you would need to do the training. And we do have the Doppler training on the website. Could you please send the link again for me to give feedback? Yeah, I think that's in the chat, but I'll put it again at the end. Do lymphedema wraps and will come out and assist teacher measure. Okay, so that's somebody else that comes out and assists with lymphedema. That's great sharing. Thank you, Rachel. How often should we be doing leg ulcer updates? Oh, Charlotte, you've got your hand up.
It was I think it's 3 yearly. Is the update. And I just want to clarify that the wound management training is fully booked for everyone for the rest of the year. It isn't just primary care, it's NHFT as well, so we will be looking into that. So it is fully booked for everyone, which is amazing that you guys are so receptive to it. So we will be looking, it's not just primary care had their noses pushed out, it's fully booked, no one can get in. I've just put my hand up again, but physically there is no more spaces for anyone at this moment in time.
I think we'll probably, I think we've got a meeting with yourselves and Paula, so we'll get something sorted. Have we got any other questions? How often? You've answered that one about the updates. Perfect. And I think we've got that information on the web page as well about the updates and how often you should be doing it. So hopefully that, when it's completed, will be a good resource that you can hop onto. I think that's the last of the questions. I do keep saying that though, they keep popping up, which is great. Thank you, ladies, for coming today. Everybody's getting a lot more time back. They're getting almost an hour back, which is amazing. We will have the next PLT. I can't remember, it's not in front of me. I feel like it's July. I think it's July. We'll have that promoted probably within the next 3 weeks. We're just waiting on speakers to confirm on topics, and then we'll get that out. I think that's the last of the messages. So I just want to thank everybody for their attendance today. If there's a question that you felt you couldn't ask, ping it over to me. I think most people have got my email, but I'll put it in the chat as well, and then I can ask these lovely ladies off the cuff if anything comes in. I'm happy to share any of that. And I think that's it. If that's yeah, I hope you have a lovely rest of your afternoon. Thank you, ladies.
Take care, everyone.
Thank
Bye-bye.
you. Bye.
Take care.
Thank you.
Bye.
Bye-bye.